Good afternoon. Myself, I am Vinitha Angalan from Manakala Vinayagar Medical College, Pondicherry. I am here to present a case of Leber idiopathic stellate neuroretinitis, a case report. Coming to the case presentation, a 26-year-old male presented to ophthalmopedy with complaints of gradual, painless diminution of vision in the right eye. For past 15 days, there were no history of redness, watering of eyes, no history of any ocular trauma or surgery, no history of any spectacle usage, no history of fever, vomiting, rashes, or no history of any contact with a dog, cat, or other pet animals. There were no other constitutional symptoms. Past history, patient is not a known case of diabetes, hypertension, or tuberculosis. Family history, no other similar ocular complaints in the family members. Personal history, the patient had a normal bowel and bladder habit. General examination was normal. Vitals were stable. Pulse and BP were stable. There were no meningeal signs. Systemic examination was all normal. On examination, the head posterior was erect. Facial was symmetry. Ocular position was orthophoric, and extraocular movements were full and free in range. Coming to ocular examination, the visual acuity in right eye was 612, not improving with the pinhole. Left eye it was 6.6. Color vision was impaired in the right eye when compared to the left eye. Other findings were within normal range. Pupil were ill sustained in the right eye. Left eye was round regular and reacting to the light. On fundus examination, media was clear. In right eye, the media was clear. Disc showed hyperevic disc with 360-degree blurring of disc margins present along with a splinter hemorrhage near the disc inferiorly. The cup disc ratio was not appreciable, and the arteriovenous ratio was obscuration of vessel from the disc was seen, and veins were dilated and tortuous. In macula, there was a macular fan with macular edema. VEP was done, which showed latency of 107, and amplitude was decreased when compared to the left eye. ERG was normal. Field testing showed a centrocecal scotoma, and fluorescent angiography showed diffuse leakage from the disc. OCT macula showed thickness. The maximum thickness was at the nasal quadrant of 337 micro-mm, and the OCT RNFL also showed thickness of 208. This is the fundus picture of the patient. In the right eye, it's showing the 360-degree margin to the disc along with the macular fan with the macular edema, whereas the left eye was completely normal. OCT macula showing macular edema, and the RNFL supporting the diagnosis of papillary edema with increased RNFL thickness. Initially, the patient, on the day of presentation, the patient ampular grid showed this type of centrocecal defect. In perimetry, it supported the finding. The investigations, the above mentioned investigations were made, and it came out to be, all the investigations were negative. The treatment, the patient was started on IV methyl prednisolone for 3 days, followed by tablet prednisolone 40 mg and gradually tapered. During subsequent follow-up, the visual acuity of the patient was improved to 6.9 in the right eye. The central cecal scotoma gradually decreased in size, and the macular edema as well as decreased. The fundus of the right eye showed margins well defined and with a cup disc ratio of 0.3, and the macular fan was reduced but still persisted. On the day of presentation, the eye of the patient was like this, and subsequent follow-up, the margins were well defined with the reduced macular edema as well as the hard exudate. This was the ampular grid showing the decreased central cecal scotoma. The macular edema was decreased in the right eye when compared from the day of presentation during the follow-up, and as well as the disc edema. So coming to the discussion, the neuroretinitis is a type of optic neuropathy characterized by an acute unilateral visual loss with optic disc swelling and macular star around the fovea. The salient characteristic of this condition is usually unilaterality, stellate macular exudate, spontaneous resolution, and unknown etiology. It is usually idiopathic, but infectious causes such as syphilis, Lyme disease, cat scratch disease, toxoplasmosis, and viral infection should be considered. The fundoscopic appearance helps to differentiate it from the common forms of optic neuropathies such as papilledema, ischemic optic neuropathy, optic neuritis, compressive lesion, toxic and nutritional deficiency. Although the neuroretinitis can mimic any of these entities and poses a diagnostic challenge to the physician, in the idiopathic variety, the patient is most likely to recover vision within weeks to months, and the role of steroids as a treatment remains unclear in both the primary and the secondary type. These are my references. Thank you.
Thank you, Dr. Vinitha. Just a couple of observations. I would say one, of course, the absence of an definitive relative afferent pupillary defect shows that it was not an optic nerve per se, and yes, the other differential of a neuroretinitis with the overlying edema. Was a fluorescein angiography done in this?
Yes, sir.
So, what did the fluorescein angiography show?
It shows a diffuse leakage from the disc, sir. It was done outside.
Okay, so an FA done outside was showing a diffuse leakage from the disc. Okay, sure. The other thing was that in neuroretinitis, you do not need IV methylprednisolone as a first line therapeutic measure. I mean, you are I mean, whether it's infective or idiopathic in either case,
Yes,
steroids
sir.
oral may suffice. You are not looking at the megadose therapy.
As the patient was a bit anxious about his vision and he was planning to go abroad for some work, we started on faster recovery. It might increase the vision faster, sir. So we started on IV methylprednisolone.
Sure. Like I said, it's not currently indicated or necessary. If at all, you could even have just given a loading dose so that the patient gets an immediate high levels of steroid.
Yes.
And you did not give any cover of antibiotics when you were giving these steroids?
No, sir, we didn't give antibiotics.
Because there are some
No
underlying
infectious.
there are often some underlying infections which we don't test for or we don't get picked up. So those are generally on the safer side. We would prefer to give a cover of an antibiotic.